All right, good morning, everyone. We are on 12, so we will start. I'm Maylene Shanking, and I bid you a warm welcome this morning on behalf of the Health Policy and Systems Division. We are hosting the noon meeting today. So in our noon meeting today, we will share some reflections from a series of advocacy briefs that explored the impact of COVID on children. And we're just going to be able to have a short part of that conversation, which is actually a very long conversation to be had. So we are all aware that when COVID-19 hit the South African shores early in 2020, there was frenetic activity that took place in order to equip the health system to respond to the anticipated numbers of adult infections and hospitalizations as a result of COVID-19. But the same held true for all other societal sectors, including a huge amount of activity that happened in civil society. And as we would all recall, the threat was scary, it was new, it was overwhelming, and many new interventions and safety measures had to be put in place. It was quite a time for us. In the health system in particular, we had to set up new governance structures at different levels, from facility level onwards, to plan and set things in place and monitor the progress of this pandemic. Here in the Western Cape, for example, for those of us who had engagement with it. We have the Silver Command sitting at district level. We have the Gold Command structures at provincial level, and every other health facility, every sub-district, every organization puts similar governance structures in place. Our university, for example, here had to put a COVID response team together and so forth. So in all of this, new resources had to be mobilized, existing resources had to be reallocated, new teams were formed, existing teams were repurposed, numerous policies and plans were made at dizzying speeds, and information changed almost daily. And many people had to step into new leadership roles and new spaces. And in and amongst all of this frenetic activity, the potential impact of this pandemic on children was largely overlooked initially. It was unanticipated, it was unplanned for, and in none of the governance and planning structures in the initial phase of the pandemic response were purposive responses and plans made to identify, preempt, and address children's needs. And when it finally started to happen, the responses were piecemeal and uncoordinated. And as a result, significant collateral consequences for children occurred. And so it's against this backdrop that the series of advocacy briefs were developed. So it's a great pleasure this morning to be able to host this conversation and to be able to welcome our colleagues from the Children's Institute, as well as the many other collaborators on this advocacy brief series. I think it's well over 40 people. So to kickstart the conversation, I'm delighted to introduce my friend and colleague, Laurie Lake, who is the communication specialist at the Children's Institute. She's also the chief editor of the brief series. And for those who do not know, Laurie is also the driving force annually behind the South African Child Gauge. And so she plays a huge role in that respect in the Children's Institute. So Laurie is going to start off by giving us an overview of the Advocacy Brief series and to contextualize the series for us. So Laurie, very welcome and thank you for joining us. And so over to you for the first couple of minutes.
Thank you, Maylene, and it's a real pleasure to be here. As you can see, we entitled the series Children and COVID-19 Advocacy Briefs in order to prioritize children, not simply in our response plans, but also all the way through to recovery. The motivation behind the series, as Maylene has mentioned, is that although children were mostly spared from severe infection, government's efforts to curb the spread of the virus and to address the very large burden of adult infections has had a profound effect on children, including the impact of lockdown and the economic recession, which has really deepened inequalities in our country. It's deepened the levels of poverty and hunger felt by children, and intensified pressures and the threat of violence within the home. And at the same time, it severely limited and constrained children's access to essential support systems through extended family, through school, healthcare, early childhood development, and social services. At the same time, we're acutely aware that children are more vulnerable than adults to both the immediate shocks and enduring impacts of COVID-19. And this is particularly the case in sensitive and rapid periods of development, such as the first 1,000 days and adolescence, when exposure to poverty, hunger, violence, and other forms of adversity can cause irreparable harm to children's immune systems, their developing brains, their education, and their employment prospects. So really the primary intention behind the briefs has really been to make visible the impact of the pandemic on children and children's services, and then to identify opportunities that exist to strengthen systems and to improve outcomes in order to better support children, not only in future waves of COVID-19, but also in similar crises. And we framed these not as research briefs, but as advocacy briefs, because we intentionally wanted to call on both government and civil society to really put children at the heart of our COVID-19 response and recovery plans. The briefs themselves are focused primarily on the Western Cape, in particular because we have strong administrative data to draw on to track the impacts on children, particularly within the health system. But even within this relatively well-resourced province, it became abundantly clear that children's needs were initially overlooked and in many areas continue to be overlooked. And what we're hoping is that the series will also provide food for thought, will stimulate a similar process of reflection and engagement in other provinces around the country. The briefs look at children fairly holistically. They track the impacts across 7 domains. The first looks at or calls for a child-centered approach to COVID-19 healthcare. The second looks at the disruption of routine health services. And then we have a series of other briefs looking at nutrition, violence and injury, mental health, early childhood development, and the role of schools as nodes of care and support. And perhaps just to end by noting that the briefs emerged out of a process of partnership and collaboration with generous support from the Children's Hospital Trust and the Michael and Susan Dull Foundation. And it would not have been possible without both the expertise, dedication, and after hours efforts of many of our contributing authors, some of whom are with us in the room today. So we're sharing the findings with a huge sense of gratitude and also hope that they will really start to make a difference for children. So I think that's it from me. Thanks, Maylene.
Thank you very much, Laurie. And just to remind everyone, we had placed the link to the briefs that sit on the Children Institute website as part of the invitation to this noon meeting. So please feel free at any stage to go and look at the briefs, download them, use them, advocate for children with them in whichever spaces you find yourself. So I just wanted to warmly welcome all the other members of the author teams. There's several in the room. We would have loved to present all the briefs to you in detail, but there simply isn't the time and the space for that. And of course, we could return at another noon meeting if that opportunity arises. So this morning, we're going to present some of the briefs to you. And we're going to start off with the first two that specifically look at the impact of COVID in the more direct healthcare setting, where children have acquired COVID and had to be hospitalized as a result of that. And we're also going to look at the impact of COVID on broader child health services and what the fallout of the pandemic was in relation to those services that children have to access. And for those presentations, we are wonderfully privileged to have with us two of the authors, Heloise Pace and Thandi Wessels. Both Heloise and Thandi are pediatricians. Heloise work primarily at the Red Cross Children's Hospital, and she's also part of the Department of Pediatrics and Child Health here at UCT. And Thandi is the child health specialist that coordinates child health services in the Metro West part of the Metro District, and she's part of the Department of Pediatrics and Child Health at Stellenbosch University. So a warm welcome to both of them. And there's other contributors to those series of briefs. Yakumari, I see you in the room, for example. Erna Morden from the Western Cape government and is also an honorary staff member in the school. She's also here. So I'm going to invite you, as you're listening to our colleagues, to post any comments that you have, any suggestions for responses, any questions of clarification that you might have in the chat session, and we'll see how we can deal with those as the time permits. So feel free to continue the conversation in the chat session. And of course, many of you also work with children in different spaces, and you can also contribute your thoughts on the issues. So first up then is Heloise, and I'm going to invite you now, Heloise, to share your slides and to take us through your part of the presentation, and then you'll be directly followed by Thandi, and then we'll take a little bit of a pause.
Hello, everybody. Good afternoon. Can you see my slides?
Not yet, Heloise. Just try and reshare. Laurie, did you stop sharing just to make sure?
Yes, I did.
Yeah. So Heloise, you might want to just email the slides to me and let's see. Okay, we still don't see it. Simpiwe, any advice from you?
Coming through now.
Ah, there we see it now, Heloise. Thank you.
Which one can you see?
The one with your notes.
Okay, that's not the one I want you to see.
But we also see the front slide, which children have COVID-19.
Louise?
Hello?
Yeah.
Just go to the display settings. Just click on, you can open it again.
Can you see it now?
Just go to display settings.
Yep. How's that?
Okay. I can see it. So
Perfect.
that's great. Thank you. Thank you, Heloise.
Thank you very much for inviting me, Maylene, and I would like to acknowledge my colleagues who contributed to this brief. I would also like to acknowledge all the frontline staff, nurses and doctors who have been at the front line doing their very best during this pandemic. Okay. So what we hope to do with this is to trace the impact of COVID-19 on children in the Western Cape. Just see if I can move. Right. So we need to start by acknowledging that childhood is a precious time with a narrow window of opportunity to address their healthcare and holistic needs and cannot wait for COVID-19. As the pandemic broke, disaster management stepped in. Testing and cohorting and separation was planned in all hospitals. Adults guidelines were immediately available. The NICD person under investigation definition specifically excluded children because of the overlap of common respiratory illnesses. However, in pediatric hospitals or wards where there were children, visiting rights were removed, and the children's wards, however, did manage to maintain one caregiver per child. The risk to staff and caregivers in children's wards has been a major player in the planning and reorganization of hospitals. It all seemed so organized. Since the start of the pandemic, there have been over 500,000 cases of COVID-19 in the Western Cape. 31,490 have been children under the age of 18. 2,624 children have been admitted to hospital, and so far 91 children have died of or with COVID-19. And thanks to Erna Morden for these numbers. So despite appearing to be a drop in the ocean, thousands more children have been affected by the illness and death of family members, with over 1 million children around the world estimated to have lost a primary caregiver from March to April 2021. Children's needs were sidelined. Resources were diverted from pediatrics to adults' COVID care. And there were concerns around infection, and advice was led to separate infants and children from much needed family support, not only in hospitals, but some of the advice actually extended to household level. And there was a real danger of deaths from other non-COVID related preventable causes. Over time, child health specialists convened and succeeded in advocating for more child and family-centered approach. Contact tracing was set up. The care of neonates and children in hospital was set up in order to minimize the stress and improve patient outcomes. We also needed to consider children in need of care of protection when their adults were admitted to hospitals with COVID-19. Pediatric guidelines were eventually developed through close partnership within the provincial pediatric advocacy groups. Did the health system provide child-centered COVID-19 care? Well, not really, actually, not initially. Everything was very adult-focused. Q&I facilities were set up with adults in mind. Children were put into single rooms without support and supervision. Intermediate care facilities were not an option to place children there because of the risk of super spreading to other vulnerable children and staff. Social workers were unable to place children without testing, although primary healthcare facilities were eventually capacitated to do this. All hospitals with pediatric wards made a plan, and as the NICD said to us at the beginning, I'm sorry, we don't have a plan for children. You pediatricians sort it out and make a plan. Did the health system provide child-centered COVID-19 care to newborns and their mothers? Well, yes, they did. And this was because the provincial neonatologists elaborated on many of their plans, and I'm showing you what Mowbray Maternity Hospital put into place. At that time, research indicated that transmission to newborns was quite rare. General preventive measures were set up. Breastfeeding was continued to be promoted. Donated breast milk continued to be supplied, and all this was supported by recommendations from UNICEF and WHO. The COVID-19 positive mothers and baby diets were kept together if both were well. Spacing within the KMC rooms was controlled. SOPs were developed in order to manage these COVID-19 exposed and positive babies, and neonates were managed in closed incubators. So our mothers had 24/7 access. However, the fathers were excluded from direct contact, and video calling was encouraged. With regards to adolescence, it seemed that initially the wave 1 and 2 caused seemingly mild disease, but the Delta variant was less sympathetic, and a fair number were being admitted. And the problem of adolescents has always been they're too old or too young. They hate being in younger children's wards. The adult wards are extremely terrifying, with death, dying, and critically ill all around. They need their own protected space with an adolescent-friendly ethos. Their family members need to maintain close contact with them. Keeping up with schoolwork and matric exam preparation has been highly stressful. Staying away from friends because of the avoidance of social gatherings. The adolescent ward, for example, at Kritiskia was closed and given to the adults. And although the beds in theory were transferred to Red Cross Hospital, actually only 10 beds were opened. Growing up is hard, and this time psychosocial support is critical. Children with other health conditions were sidelined in terms of the massive task shifting. Backlogs and delayed presentations ensued. Vulnerable children seem abandoned. For example, these were the children who attend developmental clinics and cerebral palsy clinics. Yesterday's elective surgeries became converted into emergencies as lists were curtailed. Telehealth was introduced. Appointments were deferred. Scripts renewals were supplied, and the pharmacies were encouraged to provide larger supplies to last for more than 1 month. And although critical outpatients were retained, for example, burns and fracture clinics, and renal and cardiac clinics, some patients did not arrive. And chronic health conditions began to simmer at home without a good plan for how to find these children. Stress levels were high, with more than 60 million people across the country as the country moved into hard lockdown. There was unprecedented loss of parents and grandparents and very close family members. Every family was affected. Everybody knows somebody who had died. There was loss of job and family income, with untold poverty and hunger. There was no fun. Friends were not allowed to visit. There was no money for data. Schools and ECD centers closed intermittently, despite the fact that current evidence shows that children are not driving the pandemic. The adults are. And children and their education and their development have been used erroneously as a tool for fighting the pandemic. The loss of learning through school closures and remote teaching will have a profound impact on loss of educational achievement and early childhood development. The mental health aspect must not be underestimated. The demand for social work services has been extremely high, and thanks to the Michael and Sudal Foundation, they have provided quite a bit in terms of their support to the Red Cross Children's Hospital. Children are profoundly affected when their caregivers fall ill or get admitted or go into Q&I, or worse still, die. They need intensive support during this period of anxiety, separation, and bereavement. They need information, honest information on the illness, the treatments, and the prognosis. However, it does need to be delivered with sensitivity. RX Radio, which is the only children's radio led by children, which operates from Red Cross Children's Hospital, has done a lot in terms of providing a safe platform for children to talk. And children have spoken honestly about what coronavirus has done to them and how it has affected their underlying chronic illnesses, and the fear that they've all faced. Another child, Tabile, talks about how he needs to do his schoolwork, but he'd rather go to school and he can't cope at home because there's so much noise and it's not like school. However, the appointment of the Western Cape Children's Commissioner, Christina Nomdo, in June of 2020, has done much to promote, protect, and support the rights of young children with their participation. And finally, did and do children die from COVID-19? Well, this is a track record of what has happened since May of 2020. And yes, there have been children who have died. And did they die of COVID-19? We think that only the minority have. We think that the majority of those who died, who tested positive, died with COVID-19 and some other underlying condition. And until the data are inspected, we are still all guessing at this point. Thank you very much, Maylene.
So thank you so much, Heloise, for that really illuminating presentation and for, I think, demonstrating across the life course of children how COVID had impacted on various phases of their lives. We have a comment in the chat session from Rensha Kalipski that speaks to how they've had a conversation this morning of the impact of COVID on children and a number of children having been orphaned as a result of the pandemic. And we haven't even begun to get to grips with those aspects. So thanks so much for that wonderful overview, Heloise. So Thandi is going to speak to us now about how other child health services have been disrupted as a result of COVID. So over to you, Thandi.
Thanks. Thanks, Maylene. I'd like to thank everybody for the opportunity to speak today on behalf of my team, and I'll be talking about the disruption to routine health services. So we know that maintaining routine health services for children is essential to ensure that the overall health is not compromised, and the positive gains that have been made over the past few years, such as the decrease in under 5 mortality rate, is not lost. Maternal and child health services were deemed essential, but because of the high burden of adult disease, inevitably it was required that there's a reallocation of resources, de-escalation of some child health services, and as Heloise mentioned, cancellations of outpatients as well as surgeries. What was the impact on primary healthcare services? So we saw a decrease in the number of children attending primary healthcare facilities for various reasons, including things like travel restrictions during the hard lockdown, lack of public transport, financial constraints, as well as unwillingness to actually attend facilities out of fear of being exposed to COVID-19 as well as dying from COVID-19. There was an initial decrease in our immunization coverage, as well as a decrease in the postnatal and routine well baby visits. And this was seen especially during the hard lockdown in 2020. Just move to my next slide. What am I doing? Just apologies. There we go. When we look at our primary healthcare indicators, we saw that the number of births remained relatively stable. Nobody stopped delivering, but we saw an increase in infants testing positive for HIV at 10 weeks, and this increased by 57%. The numbers were relatively low. It went from 28 to 44, but we must appreciate that in our province, we are looking at even eradicating mother-to-child transmission. So this is a huge setback. The number of children under the age of 15 on antiretrovirals, as well as the number of children started on antiretrovirals, was lower than in previous years. And in fact, we've also seen in clinical practice, we've seen children presenting with severe and more complicated disease. And sadly, this has also been seen with tuberculosis, which we know is a grave concern, especially in our province, with more children presenting with severe TB as well as TB meningitis. The total HIV testing in the province dropped for adults, with a 50% decrease in May 2020. In this slide, we can see the drop in testing in children between 18 months and 5 years. So we know if we're not testing, we're not picking it up. So this is another hidden burden. Looking at the impact on hospital services, we know internationally there was a decrease in admissions, and this was also seen here in our province, with almost 15,000 fewer admissions in 2020. And this begs the question, where are these children? They were not seen. Our mental health visits for children under 18 years decreased by 26% from 2019 to 2020. Pre-COVID, this number was already not optimal. we know with various difficulties with adolescents seeking help. Our impact on hospital services. We, as Heloise mentioned, hospital beds were reallocated due to COVID-19 care, and we are it still has not been fully restored. Intermediate care facilities open, which we know were mostly directed towards adult care. The de-escalation of services impacted children with long-term health conditions, this is due to outpatient services as well as surgeries that were cancelled. And lastly, although there were fewer hospital admissions, our in-hospital mortality rate was higher than in 2019. So in the Western Cape, very few children actually die in our hospitals, but we saw that there was an increase during the pandemic. Why is leadership and advocacy imperative for child health? So we know that provincial leadership and guidance were essential in the coordination of the COVID-19 response to advocate for child health services. At the beginning of the pandemic, there was limited epidemiological knowledge about the disease in children. And as Heloise mentioned, the POI definition was the same for adults and children, and this was fraught with problems because of children presenting with common respiratory illnesses. There was also limited testing capacity, information and guidelines were changing rapidly. A multidisciplinary pediatric provincial pediatric COVID-19 working group was then established to coordinate efforts and share knowledge. A provincial task team was also then appointed to develop a maternal and child health services response plan. And this was really to also consolidate and coordinate all the efforts that were happening in this space by the various pediatricians. We also had a Metro District Health Forum, which previously looked at addressing our surge season, so illnesses and deaths from diarrhea and pneumonia. And this was repurposed to address the impact of COVID-19. It was driven by our district pediatricians, and this drove an intense effort to improve our immunization coverage. And it also included a wide range of activities and communication strategies, including radio shows on local and national radio, SMSs, community healthcare visits. Just coming to some of the innovations. So harnessing community-based services really was one of the most innovations that we had. There was the delivery of chronic medication, the innovative use of technology, such as telemedicine. We also had improved surveillance systems as well as communication strategies. Coming to our recommendations, the best interest of the child should guide every facet of the system's response. So firstly, leadership and advocacy needs to be at every level of the healthcare system. Essential services for children should be protected and sustained. We need collaboration between key role players. Epidemiology and disease surveillance reporting is important, and we need to ensure appropriate allocation of resources for basic health services for children, as well as implementing strategies to address service backlogs and restoring child health services. And then also community health workers, their role in child health at the household level should really be optimized and provide a bridge between communities and health services. Our recommendations for child-centered care: protect resources and essential non-COVID pediatric care, which is similar. Each child admitted to hospital needs their bedside caregiver. We need the mother and the infant diet together, and we need to promote breastfeeding. We need to provide care and protection to children when their caregivers are hospitalized with COVID-19. We need to provide access to child-friendly information and safe platforms to talk about experiences and for them to express their concerns, as well as advocating for affordable medicines and diagnostic tests for children. And lastly, we need to ensure that there are child health reps supported by clinical governance team to guide national and provincial command structures. Thank you.
Thank you very much for that wonderful presentation, Thandi, and for also laying down the gauntlet for us with your succinct set of recommendations, both for some very specific recommendations around child health services, but also the broader aspects of how we organize our health system to adequately identify and cater for children who are in need. And of course, we recognize that it's not just the health system, but all the other sectors around us that determine whether children's health and health needs are adequately met. So I'm going to, before we go on to our next speaker and our final speaker, I'm going to just give 5 minutes to see if there's anybody from the audience that would like to just raise a comment, raise a question very briefly and succinctly, if possible. So there's a comment from Virginia, which I can't now immediately see. So Virginia says, Virginia Zweigenthal, as the COVID wave surged, children were not included in the eligible groups for testing unless they had comorbidities. So she wants to know, what are our thoughts about this? Did children lose out again by not being included in the eligible groups for testing, and particularly with the Delta wave? In the private sector, children could access testing, but not necessarily in the public sector. So I'm going to invite anyone from either Heloise or Jaco or Thandi or Erna, perhaps you, that's been working very much with the data as well, to comment on that. So yeah, so just unmute and comment.
If I can perhaps just say something, Maylene, in
Sure.
response to that. So this, in fact, has
Thanks,
been
Heloise.
the subject of much debate.
Mhm.
We don't have capacity to test every child. And in
Mhm.
fact, within this province, we've got different testing criteria. So, for example, I know that at Tygerberg, they test all admissions and all their caregivers, whereas at Red Cross Hospital, we only test children who leave the short stay ward or the ground floor
Mhm.
and go into the general wards or the subspecialty wards or the surgical wards or ICU above the ground floor. Now, what does that mean? Does that mean that all the children in the short stay ward are not PUIs? Well, actually, by definition, they all are. So because we don't have capacity to test all of them, what we do rather is practice the infection control measures, the distancing, the PPE to the staff, the masking of all caregivers and staff and all children over the age of 2 years. Now, it's not perfect, but we have not seen an increase in the number of staff in the short stay ward getting COVID.
Thanks, Heloise. So it seems that as we are progressing along, even though we've learned quite a lot already, there's consistent need to go back and think about what our practices are. Are we doing it consistently? Are those practices potentially harmful? Are they potentially missing out important constituents, and in this instance, children? And again, as Virginia points out, the discrepancies in practices between public and private sector, and as Heloise points out, the differences in practices within the same sector and at different facilities. So it's an ongoing pursuit, this pursuit of getting our systems right, putting things in place that are consistent and clear. So I don't see any other immediate questions or thoughts. So I'm going to move on to our next and final speaker. And within the pandemic, as has been the case before pandemic, mental health is very often a very neglected aspect, both of child health as well as adults. But in Thandi's presentation, she highlighted that even though mental health visits for children had been suboptimal before the pandemic, during the pandemic, a considerable decrease of close to 26% of mental health visits had occurred. So Mark Tomlinson from Stellenbosch University will now speak to us and give us some sense of what, if we do have a sense, Mark, because I know that there's very much that we don't know about the mental health impact of the pandemic on on the population at large, but in particularly on children, and in particularly on young children, where the manifestations of mental health are sometimes a bit more obscure. So over to you, Mark.
Thanks, Maylene. Can you hear me all right?
Yes, we can hear you perfectly,
Great,
and we can also see you.
Cool. I don't have slides. I'm just going to share some thoughts, mostly drawn from the COVID brief that my team and I put together a month or so ago now. I mean, maybe just to start off, to follow up what you were saying, Maylene, which I think is very important, is that the data we have currently on young children in South Africa, the impact of the pandemic, older children, and even in the broader the broader society. There's data. It's limited, but there probably is a time when one can quite legitimately say some things you don't need the measurement of a mental disorder to know that things aren't good, because we know what all the risk factors are for increases in depressed mood, in terms of many of the struggles that children and many people are going through right now. And when those risk factors and those associated factors are there, we can fairly safely assume that there are going to be many children and many families who are struggling. So perhaps just to preface that, linked to that is, and again to this audience, this is not going to be a surprise. What the pandemic has done is just revealed many of the fissures that were already there. That if you're poor and if you're vulnerable and if you're in a remote area, your access to testing, your access to services was already limited, and the pandemic only served to increase that. And whether that's directly related to the pandemic or all the other associated drop-offs, for example, in TB testing, and that then all the increases that we're going to see in TB and any number of other infectious diseases, kind of goes without saying. I also wanted to just do a little bit of a pitch for a book that I've just been reading, and I'm halfway through, so I haven't read it, but it's had quite an effect on me, and it's as much a polemic as a use of kind of evidence, medicine to actually make a point about broader societal issues such as social justice issues and a number. And the book's called Inflamed, and it's by Rupa Maria and Raj Patel. Many people might know Raj Patel. I think he's a research associate at Rhodes University, although based in the United States, and it really tries to speak to the kind of almost the biological mechanism of what we're going through, inflammation, and how inflammation of the body we know is related to mental disorders, how it's related to, for example, the chances of much higher likelihood of dying from COVID if you're infected, and how inflammation is related to poverty, to trauma, to adversity, which makes people more vulnerable when they're living in poverty. So I just wanted to make a pitch for the book because it's had quite an effect on me. In terms of, as I've said, that some of the best data on the impacts of the pandemic on child mental health has come from the UK and their birth cohort studies, which are which have been going on for decades. And there's been an increase in sleep disorders amongst children and adolescents, significant increases in children being terrified of leaving the house because they've either got a pre-existing condition or not, just because of extended lockdown. But one way I would like to frame a discussion is to not fall into the trap of seeing mental health as an either-or phenomenon. Either you've got mental health, or your well-being is good, you're happy, or you have a disorder. That in fact it's far more useful to see it as a continuum, and that whether it's children, whether it's adolescents, whether it's adults, we all move along that continuum in one way or another. And on the one end of that continuum would be happiness, good health. And on the other extreme of that continuum would be a severe mental disorder, such as a psychosis, schizophrenia. And as one moves along, one moves closer to a severe mental disorder or a diagnosis. But in fact, we move along this continuum. And we did some work as part of the NIDS CRAM data, and one of the things we looked at, and this was not children, was adults, but there've been 5 waves in total, 3 waves where there was a few short questions around depressed mood using the PHQ-2, so very, very, very quick and dirty, as it were. But one of the things that struck us was not so much that people were struggling with a kind of a chronic sense, but rather how many people, well over 50%, at one of those waves was dipping into a risk of a disorder, into a depressed mood, and then they would drop out again. And we used the term churning for it. And I think that's one way of thinking, is how people move across this continuum. And I think that the same is true for children. In thinking about children, someone mentioned the issue of loss. There was a paper recently in one of the Lancet journals, Global Health perhaps, by Lucy Kluver and her team, where they were looking at orphan, children who'd lost a parent or a grandparent caregiver, and they prefaced their paper with, that there are 14 million children globally who've lost one or both parents to AIDS, and that by the end of April 2021, their estimate was that 1.5 million children globally had lost a parent or a grandparent caregiver to COVID. In responding to children on that continuum, the primary site of response is always the family. It's the extent to which the family can be an enabling environment to reassure the child, to be a safe place for the child. And I say this knowing that for many children in South Africa, many families, that's not the case. But strengthening families has to be a primary component of any response. The response to a trauma, the first response to trauma, should never be the very, very first. Should never be a professional. It actually should be containment and in a safe place with a caregiver, with a professional response to follow. So this issue of loved ones and children losing loved ones, even without knowing the data, the epidemiological data to say what the impact of the COVID orphanhood, for example, is going to be on children, we know that with a massive amount of studies that have been done in the last number of decades, we know that's bad for child and adolescent mental health. And we have to find other mechanisms within the family to then contain and to respond to those children. We also know that one of the impacts of the COVID pandemic has been school disruptions and ongoing school disruptions. We currently, delivering an intervention in a number of schools in Khayelitsha with young adolescents, and even at the lowest lockdown level, the learners are only going to school every second day in most of those schools. So there's been massive disruption. And we know again from the NIDS CRAM data that there's been a 3-fold increase in school dropout. So the numbers that were estimated a few months ago was about 750,000 children had dropped out of school. Hopefully many of those children will return to school, but we also know that the longer children are not in school, the less likely they are to return to school. Again, the implications for child and adolescent mental health of being out of school, not only the academic implications of that in terms of later human capital and potential jobs and everything that comes down the line with that, but equally, if children aren't at school, they're much more likely to then get involved in taking substances, getting involved in a gang. And again, the implications for those children, for their families, and for those communities is massive. It's probably worth saying that there are some children, and I suspect a minority, but certainly it's worth saying in South Africa, often those with access to, for example, digital mechanisms of learning, where lockdown has not been a bad thing. They were bullied. School was not a happy place, and they've been quite happy in this. Maylene, I see you've got your camera on. That probably means I must stop. So
no, just a minute or two, Mark.
Cool. All right. No, cool. Just a point again, just one other point about hunger. That in fact was a big component of some of the work with NIDS-CRAM that we were doing, and adult mental health. But the same goes for children and adolescents. Is that there's a massive relationship between food insecurity, hunger, and, for example, caregiver mental health. And again, we know the impact of caregiver mental health on child mental health. And so making sure that the grant is extended, that children and families at least are able to achieve some measure of food security. In some ways, on that continuum, not on that severe end, the severe end does require services, and I'm not going to have time to talk to those, but if we're able to increase the grant, reduce food insecurity, that in itself will have a massive impact on child mental health without directly targeting child mental health. Shall I stop there, Marlene?
Thank you very, very much, Mark. And I think you've raised so many critical issues in your presentation, just reminding us of what a tremendous time of loss this was, but also how the fault lines that existed before were simply cracked wide open and had widened and deepened. And I think you touched on so many of the other briefs as well, aspects of nutrition, aspects of schooling, and the profound impact that had. And earlier on in the chat session, somebody alluded to the Lucy Kluwer study and the fact that we had lost, many children had lost primary caregivers and are now orphaned as a result, and we haven't really even begun to grapple with that. So, but also just reminding us of the importance of thinking about mental health as a continuum and not as a binary. So, so very importantly, in the chat session, Leslie raised that when we talk about access to testing, whether we're talking about access to vaccinations, access to treatment, and in some ways access to all of the service that we have spoken, there are a number of critical global inequity aspects that are at play, and where things like intellectual property barriers, commercial and economic determinants of health, political determinants of health play fundamental roles. And it's a conversation we come back to over and over and over again. So thank you for reminding us of that, Leslie. And then we had a question about including children in the COVID-19 vaccine rollout. So we are aware of the fact that there are some high-income countries that are vaccinating children from as young as 12 onwards. And at the moment in South Africa, children are not eligible for vaccine rollout. So it's the 18 plus age group at the moment, and as far as I know, there aren't any concerted plans for including younger children in vaccine rollout. So again, how do we think about children when we talk about aspects such as vaccination? So thank you very, very much, Mark. So I'm going to leave it open now. We've got a few minutes for people to raise more questions, to raise more comments. And I just wanted to mention that we have Patty Silbert from the Schools Improvement Initiative on the call, and they've done some sterling work in supporting educators through mental health education for the educators, but also direct support to educators around mental health. And they've put together a wonderful psychosocial support program that they've rolled out in a number of schools. So yeah, so to the audience, we've got a few minutes for you to raise any suggestions as to how we systematize a coordinated response for children. Yeah, any questions that you might have, any comments back to the speakers, but yeah, and also to all the other panel members and all the other authors of the series, please, if you want to raise any additional comments, please, now is the time.
Eileen, can I just say two little things? One is just, and
Absolutely.
Leslie might be best to respond to this, but there are conversations happening around approvals for vaccination of people, of children under 18. That is happening because currently SAPRA hasn't got that approval. So Leslie probably speak better to that than me, but nothing's happening, but there are conversations about that. And then maybe just to echo Leslie's point about there's something deeply structural going on that we And that book I mentioned at the beginning, sorry, it sounds like I'm the publisher or I'm not, but is a lot about that and these structural determinants and something big happening there. Yeah.
Thank you very much, Mark. So Leslie, I saw your hand.
Thanks. I can't really comment about vaccine approvals for kids. I'm not in that space. The question I wanted to ask is, school governing bodies are relatively powerful in South Africa, given school legislation. I wonder if they're powerful for a good sense or a bad sense, because given the amount of disinformation out there and what parents could decide, has that been an issue, and is that an area for intervention?
Are you just talking about in general?
Yeah, school governing bodies could make decisions about things in the schools which might not be good for the health of kids, or might be better for the health of kids than decisions that are currently being made. So I'm just wondering if that's an issue that we've thought about.
So that's an important aspect, Leslie. So here in the Western Cape, there's been an ongoing forum of discussion, advice, mutual exchanges between the Western Cape Department of Health and the Western Cape Department of Education. They meet on a 2-weekly basis, and it has not been very easy to I think, to mitigate against some of the disinformation and the practices that have developed in schools as a result. But there's ongoing engagement with principals in particular. But interestingly, as far as I know, not so much school governing bodies. And I think the point that you raised, that they could play a powerful role, sometimes to good effect and sometimes to ill effect, as we've discovered with school health and the aspects of contraceptive use, for example, and sex education in schools. They could play a very powerful barrier role, as well as a very powerful facilitating role. So I think thanks for raising that. It's something that can be taken back to that forum to ask, how do we actually actively or more actively engage school governing bodies? Leanne, I saw your hand. And I think you're going to be the last person that we will give a question to. Leanne?
Thanks, Marlene. I actually put my hand down because I thought we were out of time.
Okay, but I think we get time for a quick
trials,
question. Yeah. Leanne?
It was just a quick, were you going to give up? Can you not hear me?
You're breaking up. We're breaking up a bit, but go ahead. Let's see.
Okay,
no,
let me try again.
your
Not
audio
working.
is breaking up. Otherwise, would you like to type your issue in the comment box and I'll read it out? Okay, so while Leanne is doing that, I'm going to ask Laurie. You've raised the question, an issue in the comment box, Laurie. So do you want to talk to that issue, which is quite critical?
Yeah, I think very often when we talk about children within the health system, we assume that work is the domain of pediatricians. And yet what's become very evident, particularly in relation to questions around orphaning and the care and support and protection of children, is what happens when an adult caregiver is admitted with COVID-19. Have we in any way put in place any kind of routine question in the stationery to say, are there any children left at home that we need to be worried about? Are we putting any kind of systems in place to enable those children to maintain contact or regular updates about what is happening to their caregivers at a time which is exceedingly frightening and stressful? And my concern is that health hasn't really stepped up in that kind of way. We've begun to think about what's happening for children within pediatrics. We're doing relatively well in the Western Cape, which is incredibly well resourced. But what is happening to the majority of children who are affected by caregivers who are either ill, hospitalized, suffering from long COVID, or dead? And health needs to step in to fill that gap and to strengthen support systems and referral systems to social services.
So thank you, Laurie, for raising that. And I think you're emphasizing that child health is not just the domain of those who directly provide services to children, so through child health services, but systematizing child health and putting children at the center of the health system requires all facets of the health system to think about children and to think about their needs and to think about the responses that are required. And that includes adult health services, but also all the other components that make up a health system, not just the service component of a health system. So when we budget, when we allocate resources, when we think about staffing, when we think about information flows, but the issues that Leslie raises and also Mark raises is that the determinants of health that lie outside of the health system. So how do we connect with social development? How do we connect with education? How do they connect back with us? How do we influence when political decisions are made, that it's made with children at the center of those decisions and thinking about the consequences for children's lives. So it's very much a whole of society response that we require, and that is something that we haven't quite got right yet. But now is an opportunity to systematize interventions and responses that would take all of these aspects into consideration. Unfortunately, I don't see the point that Leanne wanted to raise, so we're missing out on her wonderful contribution. And there's a large point from Renshaw that just reminds us again that adult healthcare facilities are so overwhelmed and burnt out that they're just trying to cope at the moment with what is in front of them. But nonetheless, I think the consequences, if we don't purposefully think of the children that are connected to those adults, it has quite significant fallout effects. So I think on that note, we've arrived at 1 o'clock. And Leanne had shared with us breaking news. So that's wonderful. Just on the back of, I think, the question that we had about vaccination. That South Africa is one of 5 countries to participate in the global children's vaccine trial. The first child will be vaccinated in Pretoria tomorrow, and the trial will enroll 14,000 children aged 6 months to 17 years. So thank you very much for sharing that, Leanne. That certainly is important breaking news, and we sincerely hope that the fact that our children are going to participate in this vaccine trial, that they will have equitable access to the vaccine as would children in high income countries. And the kind of vaccine inequity that we're experiencing at the moment will not extend again to children as well, that will be the trialists for vaccination in children. So with this, I just then want to thank everyone for participating and for being present in the session, and in particular to Laurie Lake from the Children's Institute for driving this advocacy brief series, to all of the contributing authors, to our presenters, Thandi and Heloise and Mark. Thank you very much for making yourselves available today. And yeah, we're happy to come back and talk a little bit more about this important aspect. So thank you, everyone, and have a good day further.
Thanks, Maylene and Laurie. Bye.
Thank you. Bye.
Thanks, Maylene, as always, for holding it together so very, very beautifully.
Thank you all. Thanks, Laurie. Sorry we couldn't get to that last slide.
It's fine. It's absolutely fine. I think Mark was brilliant in opening things up a bit wider and speaking to the context. So it was fantastic.
Thank you. Thanks so much, Mark. And it would be really good to be able to have a longer conversation. All right, everyone. We'll see you sometime on another Zoom screen somewhere else.
Thanks, Melly. Lovely,
Thank
lovely
you,
to see you.
Thank you, Simpiwe, very much.
You're welcome.
Thank you. Thank you, yeah, for making it all happen so seamlessly. Really, really appreciate it.